Would like to begin to get into the story of the Affordable Care Act. A year ago, when we met, the advisory board, I tried to persuade John, successfully, that although the issue was very quiescent at the time, the law had been passed, the Supreme Court had decided, there wasn't a whole lot of news, that come October 1st, all hell was going to break loose. And he agreed, and hence this session. Most of you probably know the details pretty well, but I'm going to go through some basic points here. If the slides there. Good. I'm going to go through a couple of the basic points about the ACA, no long droning description, that would be too dull. Perhaps the most dramatic element of it was the expansion of Medicaid, was to add about 15 million people to the Medicaid program, which provides health care different from state to state around the nation. The Supreme Court decided that what the law had envisaged as a mandatory extension should be voluntary, and thereby roughly cut in half the number of people who, at least on first blush, are going to be covered by Medicaid, because a number of states have elected not to expand the program. There was to be a higher income eligibility, and a number of new categories were to be added. The second element, I seem to be turning things off here. There we go. Yes. The second element was a combination of reforms that really have to be thought about together, although they're often thought of separately. They mutually reinforce one another. A number of practices of insurance companies were prohibited. They could no longer refuse customers. They could not generate widely different rates for people. They couldn't use past medical experience as a basis for setting rates. Individuals were required to purchase health insurance. And in order to make those purchases affordable, they were offered refundable tax credits, subsidies, if you will, in order to purchase. The third element of the bill were a whole set of pilots and demonstrations, new Medicare benefits that were to be provided, and a whole lot more. The bulk of that gonzo bill that you've heard so much about the length of didn't concern the basic elements at the top here, but a host of miscellaneous smaller provisions that were added in as well. Now, there are a couple of background facts that it's important to keep in mind in thinking about the Affordable Care Act. The PowerPoint is a blessing except when it isn't. The first point to keep in mind about anything as large as the Affordable Care Act, okay, thank you, as anything as large as the Affordable Care Act, is that if it is roughly revenue neutral, as the Affordable Care Act is, it's spending money, it's collecting more in taxes, it's cutting some payments while it's raising others, but on the average, it's roughly a wash in terms of the budget. When that happens, you're shuffling money around, and reform is equal to income redistribution. Some people gain, and some people lose. A number of news media have been surprised, and a number of opponents of the bill have been shocked that some people have suffered losses under the Affordable Care Act. They should not have been. Anything that is roughly revenue neutral, as is the case with the Affordable Care Act, is going to generate both winners and losers. The second major feature that bears on the way in which the rollout has occurred is that ordinarily, when there is a great big new law, this is going to come as a real shocker, Congress doesn't get it right the first time. And as a result, they come back and they enact technical fixes. Furthermore, even before the law comes into effect, the House and the Senate typically pass different versions of the same bill. They're rough in each House, and much of the real work in ironing out the details occurs in the course of a conference committee where differences between the House and the Senate bill are resolved. No such conference occurred in this case. Fundamentally, what was enacted was the Senate bill. The Senate, by reputation, and certainly reputation in the House of Representatives, is less expert at crafting law because typically senators, a substantial number of them, are busier running for president than they are enacting legislation. The House is not burdened by this ambition to the same degree, and therefore they tend to focus more narrowly. There are more of them. They tend to be more specialized and expert in doing legislation. And the final factor, and here's a real shocker, is that political amity is scarce these days, which has made the possibility of revisiting the flaws in the bill, and it is generally acknowledged both by supporters and opponents, there are such flaws, that has been impossible to do. Now, I want to go into what is, in my view, the fundamental reason why there have been problems with the Affordable Care Act. Many of you take a look at what I have said in this slide, and you are probably thinking, he is deranged. This is not a conservative bill. I'm using the term in a very particular sense. When it came to reform, there were fundamentally and broadly speaking 3 options that Congress and the administration had. The first one was to move in the direction long espoused by conservatives and by Republican presidential candidates. That is, to try to replace the current collection of ways in which people acquire health insurance with an alternative under which they would buy insurance, they would be provided income-related assistance right across the board. We would separate insurance from the workplace. The market would be one of individual purchase of health insurance, aided by vouchers that would be provided publicly. The second approach was the left-wing approach, which was to create health insurance for all through a fundamentally tax-financed national system. There was only one problem with each of these. There was no chance whatsoever of enacting either of them. It was impossible to imagine a Democratic Congress and president espousing the traditional conservative program, and they recognized that there were probably 25 to 30% of the members of each house that were willing to support the so-called single-payer approach. Now, what that left Congress and the administration with was one option, and that was to accept the current system, and there it is. This is a chart taken from the journalist Jonathan Cohn, who writes for the New Republic. You can't read the details, but what is here is the kludgy, complicated, absurd system of health insurance that we have in the United States, where people are variously covered by insurance through work, individual purchase from insurance companies, Medicare, Medicaid, TRICARE, the health insurance program for Defense Department employees, myriad suppliers interacting in various ways with each of these payers. In short, what is known in the computer world as kludge. The U.S. healthcare system is a kludge. And if you want to build on kludge, then you are going to end up with something that is enormously complicated, and that is what the Affordable Care Act has done. The result of, or the characteristics of the Affordable Care Act that are currently causing grave difficulties around the nation are dual. Most of the emphasis is being placed on the problems that are currently confronting administrators and the exchanges in designing the software necessary to enable people to access insurance. But there are many other problems as well, a great many of which are going to emerge over the course of the next year or so. And I would like to just give one example of the kind of a problem that occurs routinely and in multiple ways for administrators in the United States today. Incidentally, in the little letters below the second bullet, you see a URL for access to a particular webinar. If any of you are interested in understanding viscerally the challenges of implementing the Affordable Care Act, you can do no better than to tune into this particular webinar. I would be glad to supply you with the exact address if you can't copy all those letters down here. But let me give you one instance of the kind of problem that administration is going to encounter over the next year. And to do so, consider a man and his adult son, age 27, who don't make much money. The son is unemployed at the start of the year. The man makes $30,000. He is he is separated from his wife and living apart from her. And he goes into the health insurance office in order to determine whether he is eligible under the Affordable Care Act for the refundable tax credits, the assistance to help him buy insurance. Based on the facts I just gave you, he is eligible. He is the head of household with a dependent son and will qualify for subsidies. In the course of the year, the son gets a job. The son is now no longer dependent. Question: can the man continue to receive support in purchasing health insurance? Well, the answer is no, he can't. And the reason he can't is that he is now no longer the head of a household. He is a married person who will be filing separately on his tax return the next year, and that category is not eligible for financial assistance. He probably doesn't know that. I dare say many administrators don't know that. But come next April 15th, April 15th, 2015 is a date to keep in mind. He's going to file his tax return, and what he is going to have to do is return, in the form of an additional payment on his 1040, all of the subsidies that he received in the course of the year because he is no longer eligible to receive them under the Affordable Care Act. Now, I mentioned this somewhat crazy and convoluted situation not because it's untypical, but because there are hundreds of similar such situations with which administrators and individuals are going to grapple. And I mention it for another reason. Remember the date, April 15th, 2015, because that's the date when a lot of people are going to discover that subsidies provided not directly to them, but to their insurance company in order to make insurance affordable for them, will have to be paid back because they were improperly classified or because their family circumstances changed in the course of the year. So what lies ahead? what lies ahead is that the exchanges are going to improve. That has been happening steadily since the bringing in of new staff toward the end of calendar year 2013. You may be surprised that but 8 of the 10 states that have achieved at least 100% of their targets for having individuals select insurance plans, at least 8 of those 10 states are federal exchanges, not state exchanges. California, as it happens, isn't quite there, but they're very high, and they have more people having signed up for insurance, as one might expect, than in any other state. California does have a state exchange. The second thing that is going to happen with utter predictability is that there are going to be more glitches coming down the road. I just mentioned one, the fact that come next year, a lot of people are going to suffer something akin to sticker shock when they discover that although they thought they were eligible and should have been receiving subsidies, many were not. The next thing is that we're going to have continuing political war. This is not a surprise either. It's going to continue as in this picture with the Democratic cartoon trying to do surgery and the Republican cartoon wearing boxing gloves. The other thing that's going to happen is that Republicans are going to try to thrust upon Democrats responsibility for what has proven to be, and it continues to be, a generally somewhat unpopular new law. That law is going to play out. What will occur in the course of the elections in 2014 is going to have, in my view, extraordinary importance, not just for the course of the Affordable Care Act, but for the course of American politics in many years ahead. Depending on who controls the Senate in the 2 years leading up to the 2016 election, we will either have a continuation of the relatively harmless, if you will, sniping that has occurred in the last several months, or a transition into a very, very grim sort of political trench warfare between Republicans and Democrats that will shadow the 2 years leading up to the presidential election in 2016. For that reason, the real story here is that a great deal hinges on the course of American politics and on the fate of the Affordable Care Act, which will be settled, contrary to what many people believed. It wasn't settled in 2014. It won't be settled, in 2012. It won't be settled in 2014. The date on which the long-term durability and character of the Affordable Care Act will be decided, in my view, is in the presidential election of 2016. So we have some very rough period to go through between now and then. And at this point, let me turn things over to either Kate Baicker or Mark Duggan, who will continue.
Great. Can you all hear me if I'm away from that? Good. So Hank did a great job of setting up the real complexity that we see in this law, and therefore the unpredictability of what's going to happen with insurance coverage in the coming years. I'd like to build on that to think about what expanded insurance coverage means for the individuals who are covered, for the cost to the healthcare system, for the economy overall, because those are potentially really big ticket items, and those uncertainties are going to play out in unpredictable ways in the economy. So the goals of health insurance reform, I think, could be characterized as twofold. First, cover the uninsured, and there were something like 50 million uninsured Americans. That economy, the slowdown in economic growth affects insurance coverage because most people who are privately insured get insurance through their jobs. When job growth slows down, that also limits access to health insurance. It limits people's income, so they have less money to buy health insurance. So these problems were really brought to the fore during the economic recession. The goal of expanding coverage for those groups is to improve their access to health care, their economic well-being, their health outcomes, and I'll talk about how successful that's likely to be. The second goal of reform is to slow down healthcare spending growth. And all of the success we talk about in that dimension, no one forecasts the possibility of spending less on healthcare. It's spending more, but less quickly. And that's what we're counting as victory. And it's really unclear how well the law is going to affect that. It has serious implications for individuals' budgets as they're trying to afford health insurance. It has dire consequences for state budgets and the federal budget if healthcare spending growth continues unabated. And the question of how these two goals relate to each other, I think, is one of the central ones in evaluating the reform. How successful is the reform at expanding health insurance coverage? How successful is it at slowing healthcare spending growth? And what's the effect of the first on the second? And that's a very controversial question. We've seen in the last couple of years a slowdown in healthcare spending growth. In the last couple of years, it's grown by only a little bit above GDP, as opposed to much higher than GDP growth. And there's question about how much of that is attributable to health reform versus the economy overall. Healthcare is a good where when the economy grows more slowly, in general, we spend less on it. So some of the slowdown is probably related to spending less on lots of things. But it's hard to say all of the slowdown is related to that. Some seems related to actions taken by insurers, by provider groups, potentially foreshadowed by the law, although I think less likely directly attributable to the law, given that the major reforms of the provision are just starting to bind right now. It's hard to say those have directly slowed healthcare spending growth, but maybe people acted individually in anticipation of things that were happening in the law. Maybe that contributed to the slowdown in healthcare spending growth. There's a lot of different forecasts out there, and it's a fundamental truth that when you have a 50-year trend and then you've got a 2-year post-break-in trend and everything's kind of smooth, it's very hard to forecast what's going to happen 50 years in the future. It's very hard to know how much that curve has really bent. We do know that when we spend more and more and more on healthcare, we're not likely to be getting our money's worth. And that's what really concerns me about healthcare spending. People often say, well, how much of GDP should we be spending on healthcare? We're pushing 20% of GDP on healthcare right now. That sounds like a lot of money. And if you're forecasting 30% of spending on healthcare, 30% of GDP going to healthcare, that seems unsustainable. It's not clear at all to me that that's a bad amount of GDP to spend on healthcare. If you thought that for every dollar we spent on healthcare, we were living longer, healthier, happier lives, spend 50% of GDP on healthcare. I want to live forever. What good is my flat screen TV if I'm too dead to watch it? So having healthcare spending produce longer, healthier lives, great. There should be no limit to the share of GDP we spend on it. The reason we're concerned about that is twofold. One, it does not seem like we're living forever, and we're spending a great deal of GDP on healthcare. You have to wonder if that money is being well spent. And two, more than half of the healthcare purchased in the US is purchased with public dollars. And public dollars come with a deadweight loss cost. When you raise taxes to pay for public programs like health insurance or education or anything else that's financed with public dollars, that exerts an economic drag. That exerts deadweight loss because the taxes that you raise to finance that public spending divert resources from their most productive use, makes the economy grow a little more slowly. So that extra cost associated with public funds has to be taken into account. That doesn't mean we shouldn't have public programs. It just means that in evaluating the costs and benefits of spending more on public health insurance and on healthcare more generally, we have to think, how much health are we buying, and what's the cost to the economy of raising the money to finance it in addition to the actual spending on healthcare? There is ample evidence that we are not getting our money's worth out of the healthcare system. I don't think I need to spend a lot of time on that. But here's one graph to illustrate the point. This is a graph of spending through Medicare at the state level. and the quality of care that Medicare beneficiaries receive. And you will note a strong negative correlation. In the states where Medicare spends the most money per beneficiary, beneficiaries are the least likely to get things like flu shots, pneumonia shots, antibiotics before surgeries, things that are really high quality care that are known to be cost effective. This isn't the controversial stuff. This is the uniformly agreed upon stuff, and we're less likely to deliver it in the places where we're spending the most money. These are all insured people. These are all insured people through Medicare fee-for-service, so they all have the same insurance product in theory, but clearly very different things are happening on the ground in different parts of the country. So this doesn't mean that Medicare is busy spending money for the purpose of avoiding giving flu shots. Rather, something else is interfering with the delivery of efficient health care. Maybe it's a lot of specialists and not enough generalists. Maybe people are getting really high quality organ transplants and nobody's saying, hey, you're diabetic. Have you had an eye exam? Are we monitoring your blood levels appropriately? There's some hints that it's a failure of coordination, that in the areas where we're spending a lot of money, basic and high quality care is more likely to fall through the cracks. So that suggests that reforming the financing system of health, the way we're spending money on healthcare, has some opportunity to move money away from the expensive, lower quality areas towards the more efficient, higher quality, less expensive areas of healthcare. And if we can move that money over, then we can be much less concerned about how much of GDP we're devoting to healthcare spending. There are a number of provisions aimed to expand health insurance coverage. Hank mentioned the key ones. There's a Medicaid expansion, and then there's subsidies for individuals who have income that's too high for Medicaid, but still below 400% of poverty to get subsidized or exchange policies, private insurance policies through the exchange. So there are all these mechanisms for getting people insured, that first goal of health reform. What are the costs and benefits of that expansion? How does that expansion play out into the efficiency with which we're using resources and total spending on healthcare? Well, if you ask the uninsured, they tell you that they receive much less access to healthcare, that they're receiving lower quality healthcare. If you look at the stage of diagnosis of cancer or heart attack outcomes, it looks like the uninsured are getting worse outcomes. But it's very hard to know for sure. And this is because people who are on, for example, Medicaid, look different from the uninsured. If you want to know the effect of Medicaid, you could very naively look at the mortality of people who are on Medicaid and look at the mortality of people who are uninsured, say, hey, people on Medicaid have a higher mortality rate, which they do. Medicaid is killing people. We're spending money not to give seniors flu shots and to kill poor people. Surely these public programs need to be reformed. That's not such a fair assumption to make just because of that fact pattern. The people who are on Medicaid are poor. Being poor is bad for your health. And if you don't take that into account, you're going to think that the Medicaid program is responsible for the higher mortality, whereas really it might be their underlying health, their poor health condition that got them on Medicaid, their low income that got them on Medicaid. So you need to take those things into account. It's very hard to do so in a clean way. We have some data from a randomized controlled trial of Medicaid expansion, which is very hard to come by, but it happened in Oregon because people were on a waiting list for their Medicaid program in the state of Oregon, and the state drew names from the waiting list by lottery. So this gives, as far as I know, the only randomized controlled trial evidence of the effect of expanding Medicaid on healthcare use and health outcomes. And what we saw is that when you expand Medicaid to low-income adults, they use more healthcare. Now, on the one hand, this should not be surprising. We have just discovered that demand slopes down. You know, where's my Nobel Prize? Because in fact, when you lower the price of healthcare services, people use more. This sounds like lots of other goods. The reason I believe it was surprising is that they use not only more doctor's office visits, more prescription drugs, which I think had been consistent with the hope of the expansion, they also go to the hospital more and go to the emergency department more. And there had been a real hope, loudly articulated, that if you expanded health insurance, you would get people out of the emergency department, out of the hospital, into the doctor's office, getting preventive care, and it would save us all money. And I think that this data, along with others, puts to rest the idea that expanding health insurance saves money. It costs money. People use more health care. Now, that doesn't mean that the program is bad. What happens when they get more health care? Well, we see a massive improvement in financial well-being. And I think that this is an underappreciated aspect of the goal of expanding health insurance. We all talk about the role of health insurance in generating health, but in fact, insurance is a financial product. Insurance is supposed to protect you from the financial consequences of bad things happening. I have homeowners insurance not to keep my house from burning down, but to save me from financial ruin if my house burns down. And in fact, what we see for low-income populations is that when they get Medicaid, the prevalence of catastrophic out-of-pocket medical expenses disappears. They're much less likely to have bills sent to collection. They stop not being able to pay their other bills or having to borrow money to pay their other bills because of health bills. So people are much better off financially. What happens to their health, though? That's the real punchline that people are interested in when you talk about expanding health insurance. We see that there are big improvements in self-reported health, massive improvements in depression. The prevalence of depression drops by 30% when you give people Medicaid relative to being uninsured. But we did not observe substantial improvements in physical health measures like high cholesterol, high blood pressure, diabetic blood sugar control. And this is a little bit of a mixed bag. I think there had been some hope that if you expand health insurance to low-income populations, they'll get much healthier. And that's because they have access to earlier care, preventive care, good maintenance for chronic conditions, and that their health will improve even in the span of the 2 years that we looked at. We don't see that. So what I think that suggests is that Medicaid has real benefits for people: financial security, mental health improvements, improved self-reported health, but does not cure diabetes or high cholesterol or high blood pressure, and that means better management of those conditions is in order. For those benefits, it costs society money. We have to raise money to increase, if we want to increase health insurance coverage. And the reason the Affordable Care Act is budget neutral is not because expanding health insurance saves money and doesn't cost anything in the long run. It's because there are other revenue raisers that balance the increased expenditure for health insurance. So, expanding those insurance plans that exist today is likely to generate a mix of value in the healthcare system. When you cover the uninsured with today's health insurance plans, they get today's health care, which is sometimes life-saving and beneficial, and sometimes not all that cost-effective. So I would argue that if the goal of expanding insurance is to be consistent with the goal of bending the curve, slowing healthcare spending growth, we need to reform what those insurance programs look like. They have to promote higher value use of care. For example, you could imagine having a copayment for the emergency department that was higher than than the copayment you'd face for going to the doctor. You could imagine having copayments for drugs that varied based on the efficacy of those drugs in the particular patient's circumstances. For diabetic patients, we should pay them to lower their cholesterol. It is so expensive and so likely that a diabetic patient has an adverse cardiovascular event. Statins and other medications to lower cholesterol are highly cost-effective. Whereas for another patient who maybe doesn't have any other risk factors, who has only moderately elevated cholesterol, maybe the statin should cost $20. At the same time, we need to manage patients maneuvering through the system more actively to keep them in the highest value sites of care. The doctor's office instead of the hospital, talking to a nurse practitioner instead of a surgeon. There are lots of ways to optimize the way healthcare resources are spent. There are potential levers to do that in the Affordable Care Act. There's some reforms on the public side, some on the private side. Moving towards accountable care organizations is one of the policy levers being experimented with. Accountable care organizations give providers an incentive to manage patients' care more effectively through a shared savings program, where a group of providers who manages the panel to have high quality care and good outcomes at a lower cost than was forecast in the old system gets to keep some of the money. And the goal there is to have providers steer patients towards the most effective cost sites of care, send them to the hospital that delivers the high-value services, not the hospital that has higher readmission rates, for example. If providers, and particularly physicians, can steer patients in that way, we could see better outcomes for the same amount of money, but it's not clear that provisions like accountable care organizations are actually going to work. People are very hopeful about them. We have no evidence on their efficacy because it's early on, And it's not clear that the incentives that are built in are strong enough. So even if this particular incarnation doesn't do anything, that doesn't mean that a stronger set of incentives might not work better. We just don't know. And I think the jury is still out on that. It leaves policymakers to wrestle with a very tough decision that I think the last debate over health insurance expansion and the Affordable Care Act did a disservice to on both sides. People want to make the story easy. You know, bumper stickers don't fit all these slides. They say things like, you know, expand insurance and save money, or Medicaid kills. Those black and white views of the world are clearly not consistent with the reality that patients are living in and that taxpayers are living in. But we're unwilling as a nation to have a debate that says public dollars cannot finance all care for all people. There's the miracle of modern medicine is that there's a virtually unlimited amount of stuff that we can do to people that might improve their health. That's more than 100% of GDP. We don't have enough dollars for that care for everyone, and we especially don't have enough dollars to publicly finance all care for all people that might improve their health. So great, let's eliminate waste, fraud, and abuse. We're all against spending money to kill poor people. Great, let's take that off the table. But once you've done that, you're still left with a very tough decision about care that has incremental benefit for beneficiaries and costs hundreds of thousands or millions of dollars. And there's where I think we need to reform our public programs to say, we can cover this much care for everyone, and if you want more care than that, that has to come from private dollars. And that's a debate that I haven't really seen us have in a serious way yet. So I'll stop there.
Oh, I guess, yeah. Thanks very much. I'm honored and excited to be here talking with you today about the Affordable Care Act. I'll build on some of what Hank and Kate were talking about earlier in talking about the economic impact of the Affordable Care Act. I guess I'm in, let's see here. Is this the clicker right here? Top button. Oh, no? That doesn't look good. Okay. Oh, here we go, like this. So I'll be talking about the economic impacts of the Affordable Care Act. It's a large and pretty complicated piece of legislation, and there are sort of pluses and minuses on this, and there's so many parts to it, so I'm really going to try to shine the light on just a couple of things that I think are interesting, aren't receiving perhaps that much attention right now, and could be really important as we go forward with the implementation of this legislation. So on the plus side, one of the things with our pre-Affordable Care Act system that people were very concerned about was that often people had health insurance that was tied to their employer. And about 91% of privately insured people back in 2010 were getting that health insurance through an employer. And as a result, many people ended up sort of connected to jobs that perhaps weren't the best fit for them. Additionally, this, prior to the Affordable Care Act, people who worked in small businesses were much less likely to have health insurance than their counterparts at large companies like Intel and General Electric. And that was partly because smaller companies had less bargaining power with insurers and tended to get higher rates as a result. So if you looked at people who worked in small businesses, let's say 4 or 5 years ago, they were about 3.5 times more likely to be without health insurance than people in larger companies. So one of the things that the Affordable Care Act tries to do is sort of reduce the amount to the extent to which people are locked into an existing job, and to make it easier, especially for people in small companies, to get health insurance. And the hope also is that with this legislation, through the many different ways in which Medicare and Medicaid are reformed, and in which we tinker with the private health insurance system, that we'll get healthcare costs growing at a slower rate. That's obviously hard to say right now because we're just a couple months into the implementation of the major parts of it. On the other hand, on the negative side, there are a number of potentially negative effects of the Affordable Care Act on the economy. Hank touched a bit on one of them, and Kate as well. One is basically when people are receiving subsidies through the exchanges, they are essentially going to observe that their subsidies fall as they work more, or as they get a promotion, or as their spouse enters the workforce, and that potentially could have big effects on their incentives to work and so forth. Additionally, there are a number of requirements or thresholds that affect companies. Things like if you have fewer than 50 full-time employees, you're not subject to the employer mandate. If a person works fewer than 30 hours a week, they don't count against the employer mandate. A number of thresholds that we might worry may affect how employers interact with their employees. And so these are, and just to get a sense of one of the pro sides, if you look prior to the Affordable Care Act, at the likelihood that companies of different sizes were offering health insurance to their workers, you'll see that basically it was, so here I've sort of sorted companies from smallest to largest, and off to the left you see that companies, let's say with 3 to 9 employees, the likelihood that they were offering coverage to their workers was falling from 2000 to 2009. So about 59% of companies in this size range were offering health insurance to their workers in 2000, and that had fallen to 46% by 2009. And whereas you see that basically essentially 100% of companies with 200 or more employees are offering health insurance to their workers. So one of the things that proponents of the Affordable Care Act point to the most is that it will allow people in smaller companies to potentially have better health insurance arrangements than prior to that. However, on the negative side, you can see how a person's subsidies, if they are, let's say, getting health insurance through the exchanges, here I've put up the subsidy schedule for a family of 4, and essentially a family of 4 would be eligible for health insurance through an exchange, and would be eligible for subsidies in that exchange if their family income ranged from about 100% of the federal poverty line to 400% of the federal poverty line. And what you see here is that as the family's income grows, their subsidies fall, and then when you hit 400%, there's actually a cliff. And the magnitude of that cliff is going to vary somewhat across geographic markets. My guess is in Palo Alto, it'll be about $6,000, whereas in Bozeman, Montana, it'll probably be $500, just as a function of how expensive health insurance is in these various places. But you might worry that essentially a family thinking to themselves, well, we have one person right now who's making $40,000 a year. Do we want the spouse to enter into the labor market, let's say also earn $40,000 a year? That's going to lead them to a very large reduction in their subsidy. And obviously, if I'm working in an $80,000 a year job and I'm working really hard and suddenly I get a promotion and earning $100,000 a year, that could be a problem with respect to the magnitude of the subsidy. So this is, you know, there's a lot of on the one hand, on the other hand stuff with this legislation. There's no way. So basically what the legislation does is it targets larger subsidies to lower income individuals. Those subsidies phase out with income, but inevitably that's going to create some potentially adverse incentive effects. And how big a deal this is going to be, it's hard to say at this point, but it is going to affect people's incentives to work. And I think it is something for everyone who's interested in the Affordable Care Act to keep their eyes on going forward. And this is especially important, I think, right now, because if we look at the US economy, in terms of the employment rate, it's not looking so good. The unemployment rate has fallen by 3.5 percentage points over the last 4 years, 3.5 years. But as you can see from this figure, there's been no change essentially during that time in the employment to population ratio. And what has happened is we've seen unemployment fall because more and more people are dropping out of the labor force. And to the extent that the Affordable Care Act can move the needle in a better direction, hopefully, on this front, or perhaps, you know, I think there's some uncertainty about in which direction the Affordable Care Act will move this thing. Or perhaps it won't have much of an effect at all, but there are many, many different provisions of the Affordable Care Act. One of the challenges for people like Hank, Kate, and me, as we try to study this thing, is figuring out, well, what is affecting what? Because so many things are changing simultaneously, so it's hard for researchers to get at this. But I think this is a really important graph for the US economy and for us thinking about what kind of economic policies we're implementing, not just in healthcare, but more generally. Another big question with the Affordable Care Act is whether it's going to slow healthcare costs. And so, as both Hank and Kate talked a bit about, healthcare is a big share of our economy. If you look at Medicare and Medicaid, those two programs between them insure about 110 million people in the US, and their annual cost right now is over $1 trillion. The Affordable Care Act is lowering Medicare spending through a variety of reductions in reimbursement rates to providers, while simultaneously substantially increasing Medicaid reimbursement. But over the next 5, 10, 20 years, both of these programs are going to grow quite a lot because of the aging of the baby boom population and because of the Medicaid expansion from the Affordable Care Act. But at some level, if you look at Medicare and Medicaid, how much, so if you look at the best projections of what's going to happen to them as a share of GDP, it will be growing over the next several years to 7.8%. And really, there isn't much change. The Affordable Care Act doesn't move that very much because to the extent that it cuts Medicare spending, it is more essentially offsetting that with increases in Medicaid. So these are two of the nation's big 3 entitlement programs, and I think we're going to hear a lot more about these programs in the years ahead about how to reform them. Additionally, the ACA has some important effects on the private health insurance market. So most people in the US have private health insurance, not health insurance through Medicare or Medicaid. One of the things that was very controversial in the legislation was an excise tax on high-cost plans. So many of you some of you may not know, but I think I'm guessing most of you know that to the extent that we receive health insurance through our employer, that compensation is not taxed. And so that creates a subsidy for people to get more generous health insurance than they would in the absence of it, and is part of the reason that the US spends vastly more on health care than other countries. The excise tax on high-cost plans that begins in 2018 is to some extent an effort to correct that by basically taxing insurers for plans that cost beyond a threshold, and this is called the sort of Cadillac tax on high-cost insurance plans. And then that threshold will grow just with inflation after that point. And the hope is that this will provide a powerful incentives for private health insurance premiums to grow much more slowly as a result. And whether that will happen or not is hard to say. But the reason for this happening in 2018 as opposed to 2014, part of the reason was that it was an extremely controversial provision because the tax subsidy to health insurance is a pretty popular feature of our tax code. Additionally, another lever through which the Affordable Care Act tries to affect change, potentially improve things in the private market is through these health insurance exchanges. And obviously, so far, things haven't gone wonderfully well with that. There have been some bumps in the road, but the hope is that these things will eventually make it really easy for people to go online and have an Amazon-like experience where they shop for health insurance and emerge with lots of information about their options and make the best choice. There are bronze plans with actuarial values of 60%, meaning that they basically cover 60% of your costs. Silver plans, gold, and platinum. And there are many insurers are deciding which of the, let's say, 3,100 different counties in the US to enter. And so insurers have a lot of flexibility. Do we enter in Palo Alto? Do we enter in Merced? Do we enter in San Diego? Do we enter in Las Vegas? And so forth. And so it's interesting. One of the things that I've been working on is trying to figure out how much participation we've seen by insurers in these different markets. The hope is that these exchanges will encourage really robust competition between health insurers. We'll have several insurers participating, and that will give insurers a powerful incentive to price more competitively, and then enrollees will pay the full cost difference between those plans. That's actually worked pretty well with Medicare Part D as a way to control expenditures. But one of the concerns that I have, and this is based on some research actually that I'm doing with a professor in the economics department here at Stanford, Mike Dickstein, and 2 PhD students here at Stanford, is that in many markets you may not see many insurers participating. So let's say we just take a state like Texas. Here I've color-coded each of the 248 counties with respect to how many different health insurers they have competing in these areas. And you'll see that in areas like Houston, Dallas, Austin, we have many insurers competing, but in many parts of the state there are 1 or 2 insurers. So darker means more insurers competing. And so the most common is to have just 2 insurers. Many counties have just 1 insurer. And with those subsidies that I showed before, if you don't have a lot of insurers competing, that's going to be a problem in terms of the vigor with which we're going to see competition leading to lower prices and better quality. And so that is, it's something that I am somewhat worried about. And as you can see, we're doing some research also to try to figure out how much premium variation there is. Often an insurer will often offer many plans in these exchanges, and you can see here that basically I've charted premiums for Florida, Michigan, and Texas, and this is basically pulling information from that wonderful site healthcare.gov, and it wasn't our pulling data that caused it to crash. It was that I did have someone ask me that. We waited for a while before pulling this data, but as you can see, basically here we have Florida, Michigan, and Texas. They're bronze, silver, and gold plans. And you can see on the vertical axis, this is the annual premium for a 43-year-old male. And you can see that there's a lot of dispersion in the premiums that are available. And one of the concerns that many people have is that people may be in those places, let's say Palo Alto, where there are a number of insurers competing in this area, will people be overwhelmed with the number of choices that they have? And so there's hitting the sweet spot of the kind of a sufficient number of insurers to get a lot of competition and not so many that we overwhelm people and they make bad choices is going to be a challenge for policymakers going forward. And I think, going forward, whether exchanges will realize their potential is really an open question. It was obviously a really bumpy start for the federal and the state exchanges, and enrollment has been significantly lower than policymakers had expected and hoped. It is designed very similarly to Medicare Part D, which in 2006 had a really bumpy rollout, but is now actually considered to be a success in the sense that it ended up costing much less than projected, partly because policymakers did a good job of stimulating competition, and in the end, people ended up gravitating towards plans that were less generous, I think, than expected. Some of the key issues that are on the horizon for policymakers, one is how broad should a plan in these exchanges make its provider networks? How broad do they have to make it in order for it to be okay in the view of the state policymaker? How many oncologists do they have to have in their network? And so, there is some concern that insurers may try to tailor their benefits package to appeal to people who are profitable, given their characteristics, as opposed to just competing vigorously on price and quality. And so I think these are, how quickly the government should adjust subsidies. If a person gets a promotion, should they call up and immediately tell the government so that they don't get a surprise on April 15th, as Hank was talking about? Or when people lose their job, how quickly are we going to adjust those? And right now, I think the exchanges are anything but nimble, but hopefully going forward, they can do a better and better job of adjusting subsidies to reflect people's real-time economic circumstances. And I'll wrap up there.
There are about 100 takeaways from all this. I'll ask the first question, but one comment on your graph of Texas. Being from El Paso, those 4 counties that don't have many insurers, there are no people living there either.
Right. No, I know. It is true. Yeah, right.
And to Kate, I'm still trying to get my head around being too dead to watch my flat screen TV. I didn't realize you could be dead and still enjoy your flat screen TV. So I'm working on that. I'm going to work on that all day. Hank already answered this question, but in this morning's New York Times, one of our frequent colleagues, Victor Fuchs, has an article in today's New York Times about healthcare, and he takes your point about how much we're spending more than other countries on healthcare, and he estimates that if you get away from the percentage, it's $1 trillion. And we're spending $1 trillion on healthcare for questionable benefits in this country, and there are some benefits, and as you acknowledged, and as we all know, so he then took a cut at here's what the country could do with this $1 trillion. And it's a really interesting article. And then I'm supposed to lighten things up, and this isn't going to work. But he then concludes that the politics of the United States preclude it happening. We are not going to be able to politically in this country get that $500 million or $1 trillion worth, $500 billion or $1 trillion of spending. And I'm curious if you all agree with Hank that the political morass is good, or actually if Hank agrees with my interpretation of Hank, that this is a political morass we're not going to be able to get through. And Victor.
I think if one expects to save $1 trillion in the next decade, or you pick the period, the answer is no, of course, we can't. But I think that's the wrong way to look at, not that Victor Fuchs was posing an uninteresting question, it is, but if one is thinking about the process that's been set in motion by the Affordable Care Act, the fundamental point is that every country in every situation is heavily influenced by the path they have followed to get to the present time. It establishes enormous constraints and limitations precisely for the reasons I'm sure Victor emphasized. What happened in 2010 when this bill passed is that the nation decided the status quo is unacceptable. At least Congress and the President signed a bill that said the status quo is unacceptable. What the nation decided, I think, remains to be seen. What we did was set in motion a process of change that is going to play out over a period that is going to extend beyond the lifetimes of anybody in this room, even if there are some young students. It's going to go on for decades. If we decide to continue this process of evolutionary change, the unfortunate fact is that this commitment to change has now become so embroiled in a very destructive political battle that there's a grave risk that we're going to stop in the name of one political philosophy or another, a pragmatic approach to solving the problems that I think each of the three of us described. If that process of change continues, I think what we will see over time is an improvement in the targeting of the expenditures on medical care. Part of that $1 trillion that Victor referred to goes for very high rates of compensation to some medical care providers. We're going to see some squeezing going on of that. What we're going to see is a gradual realization, I believe, of savings. That's not the right word. A gradual realization of better target effectiveness of medical care. But it's going to be controversial, bloody, and slow every step of the way because people care so deeply about their health insurance. People care so deeply about the incomes they earn from providing health care benefits that the contest is going to be slow and unpretty. It is in other countries, incidentally, as well.
Either of you have something to add?
I guess I'll just say that one person's waste is another person's income. So I think that is it creates a challenge in terms of trying to lower spending. And then on top of that, though, I do think it's inevitable that the country is going to continue to shine the light more and more to figure out how to get better value for what we spend. I mean, if you think of how much money from the view of a typical family goes towards health insurance, it's pretty enormous. The typical family health insurance premium now in the US, if you look according to data from the Kaiser Family Foundation, is about $16,000 a year. And so that's a large chunk. If you look at median household earnings, it's about $51,000 a year. So that's a lot of money from the perspective of the median family in the US. And then on top of that, if you look at the average amount of taxes that go towards government health insurance programs like Medicare and Medicaid, it's $1 trillion. There are 110 million households in the US, so it's about $9,000 plus or minus on average per household. So 15. Now so there's a lot of money from the view of the typical family in the US. $16,000 for a family plan, $9,000 or $10,000 going in taxes to Medicare and Medicaid for the average family. I think as time goes on, people are just going to demand more and more out of the healthcare system. So I'm optimistic. I think it will be somewhat bumpy along the way, but I do think it just has to happen given the economic trends that are going on in the country.
Okay.
I think Mark's point highlights the importance of financial incentives, that there is enough money in play that there's room to sweeten the pot for behavior improvement. So ACOs that I mentioned are one example. There are other models of shared savings where I think you need to share the savings of slowing the growth of healthcare spending with providers and with families, where Medicare beneficiaries who choose higher value plans through Medicare Advantage now have a floor to their potential to share in those savings. They can't get a dollar rebate. You could imagine moving towards that. You could imagine having patients have more access to funds that they save through going to lower cost providers to use for other things as well. And that gives an additional avenue, because Mark's point that somebody's waste is somebody else's income is a very important one.
Right. Questions from the floor? Yes, John.
I'm thinking about our first session, and you asked at the end when was he going to get into healthcare. But as you portray this, Henry, we're just building this huge edifice basically on a decrepit foundation.
Oh,
And it's his home building analogy. Why isn't there some separate kinds of changes that would make individuals more accountable? You want to lower the health care bill, you build up the number of regulators, you build up the number of customers, people reaching for their back wallet, which is about 15% now, I think, in health care. So one thing comes to mind. Why isn't there a national market for health insurance to wipe away the state and all its contraptions and have that as and also people can offer a wide variety of products. You go into, insurance policy that just insures for, major health events. You drop the cost of it dramatically.
So, two initial thoughts, and I'm sure Mark and Hank have thoughts as well. First point is that I think it's really important to think beyond health care and healthcare delivery when thinking about health and health spending. Part of the reason, not the only reason, but part of the reason that the US spends so much more per capita on health, or as a share of GDP on health, is that we're entering the healthcare system with much more complicated conditions. We're more overweight, we're more hypertensive, we're more diabetic than our European counterparts, we're more expensive to fix. And efforts to improve disease management, health behaviors, and the like before people enter the catastrophic healthcare acute system could be much more cost effective than trying to deliver more expensive services once the bad thing has already happened. So to slow healthcare spending growth, I think we have to think much more broadly about health policy that goes beyond healthcare, thinking about building it into housing, transportation, food, all those other policies that are inputs into health before you even enter healthcare. The second point is a more nuanced one about national markets for health insurance, and on the one hand, having more variety of products available for people to choose higher value plans surely seems like a good idea, and that's the underpinnings of both Medicare Advantage, the managed care segment of Medicare that about 25% of beneficiaries are in, and Medicare Part D, as Mark mentioned, where there are these competitive bids for prescription drug plans, and therefore there's been a lower average premium than was anticipated as people choose lower cost, higher value plans. The challenge is that one of the major tools for lowering healthcare spending that insurers have in putting together their plans is narrower networks. There's this complicated negotiation between insurers and providers before the insurance plan is then offered to consumers or patients in who's covered, who's in network, who's out of network. And that negotiation is one of the major levers for getting provider prices more competitive. As insurers are negotiating with providers, that's inherently local. So I'm not sure what a national plan really looks like, given that some of the major policy levers are at a local level. Who's in, who's out, what prices have you negotiated? Healthcare is one of those things that really cannot be delivered on a national scale. When I need to go to the hospital, I don't say, hey, there's a great one down in Georgia. Now, you might, for specialty care, fly to the best transplant place you can find. That's not the way to slow healthcare spending growth for the typical dollars spent at the local area. So there's a balance that needs to be struck between having competitive offerings of high-value plans and the negotiation that goes into those that is inherently focused at a regional or local level.
Mark, Hank?
I guess I'll just throw in that I think states have very different views about what is an adequate level of coverage. Take, for example, the two most populous states, California and Texas. They just have different views about how much should we intervene to make sure that people are protected, and so I think there's an element of sort of variation across the country in terms of the right amount of government intervention. But you said something else that I want to touch on, which is getting providing people with better incentives. I mean, I think we can do a much better job of providing people with incentives to keep their health, to maximize their health, and also to sort of do a bit to try to reward the providers that provide the best combination of quality and price. Right now, I can't imagine a system that is more opaque. If I try to figure out like what, if my son or daughter have to go to the hospital for some kind of a procedure, and it's something that we can plan in advance, how I would even go about figuring out the various choices. It is so opaque, and it remains so opaque, and it is sort of remarkable to me. And I think there are actually some companies here in the Bay Area that are trying to sort of shine the light more on the variation in provider prices to try to enlist consumers to help bring these costs under control, because right now I think consumers are kind of blindfolded when they enter the healthcare system about what are the prices, and as a result, providers don't feel really much pressure at all, except when negotiating with insurers, as Kate was saying, to try to price competitively. And I think that's a really important thing, and the more we can do on that front, I think the better the system will be.
It's a great comfort to us non-experts that this is opaque to the experts.
Right.
Hank, did you want to add anything, or are you fine?
Just two comments. The first is I agree entirely that improving financial incentives would be desirable and would help. That said, something that's somewhat in contrast, looking at all those other countries that spend so much less than we do and have arguably at least as good outcomes, none of them relies primarily on price incentives in order to achieve their low levels of spending. They use other mechanisms. So I'm a bit like Winnie the Pooh, who was asked whether he wanted sweetened condensed milk or honey with his tea, and my answer is both, please.
Yeah, I also, you made a point that I think is extraordinarily important, Hank, which is you work on the system that you got. It got here for a reason, and we have to work on that system. And I'm reminded, if the founding fathers came here today and saw our healthcare system, I mean, it's just, I can't imagine their response to it. And Thomas Jefferson was always quoted as saying you need a revolution every 30 years. And so something revolutionary probably isn't in the cards in our political system. Unfortunately, we only really have time for one, maybe two more questions. Mr. Secretary George Shultz, you have a question?
I'd like a comment on the mandate issue. I know well a family that has a large ranch up north of here. People live on the ranch. People work there. They brought up their children there. One of them even was good enough to get into Stanford. They've had a health care plan for 20 years. It's worked well, served their interests. Along comes this act, and it causes the plan to be canceled. And now they are struggling to find one. It's hard. They haven't found one yet. Anything that they find has to cover a lot of things they don't think they need or want. Their judgment is based on 2 decades of experience, and they're confronting the judgment of the act that has no experience and that's been caused to lose their health insurance. This problem is not unique. It's taking place all over the place. So would you comment on the mandate issue and the degree to which the federal government should substitute its judgment for what you need for yours?
Well, for clarification, I think the question you're posing is not so much about the mandate as it is about the requirements placed on having minimum health benefits in insurance plans. It does relate to the mandate, of course, because if a plan doesn't have those features, then an individual is considered not to be covered, and they are subject to the penalty. So it interacts. It gets back to my point that those 3 provisions, the mandate, the insurance reforms, and the subsidies, are all very tightly interrelated one with another. The fact of the matter is, at least as amended by the administrative decisions of the administration, it is within the power of the state of California to authorize that family to continue with the same policy that it had for at least 2 more years. Insurance under federal law passed during the 1950s, regulation of insurance, was made a state responsibility. In response to the outpouring of anger and upset, I think spurred by the kinds of situations you've described, the administration backed off the requirement that plans meet these insurance requirements this year, in 2014, and said that state insurance regulators would, for 2 years, have the authority to waive those requirements and allow people to retain plans. So if they have a gripe right now, it's not just with the statute, it's with California state regulators. Now, I think the long-run objective of assuring that health insurance plans routinely cover the broad range of services that people need. We went through these in the DC exchange, and I have to say, I would not like to have insurance that didn't cover the items that were listed in this menu of required healthcare services. It makes sense, it seems to me, given the upset that has occurred, to have an extended phase-in period and to accord to states the right to decide whether those rules take effect immediately or more gradually over time. There's no question that there are a lot of situations such as you described where people got along just fine. They may not have been covered for some things that are relatively infrequent and that they haven't needed in the past, or if they've needed them, they've covered them as individuals. But if you're going to have a set of subsidies to pay for insurance, you want to broaden coverage, you can't really get away from defining what adequate health insurance is. The law tried to do it in a particular way. This is one of the areas where I could well imagine that had there been a chance for a technical corrections bill, as you well know, the political circumstances made that completely out of the question. But I can well imagine that this would have been one of those areas where sensible members of Congress in the center would get together and say, we'll modify the package, we will delay implementation, we will do something to ameliorate the impact on the kinds of situations you described. It didn't happen. It's not going to happen in the current atmosphere. It's one of the regrettable features of the political divisiveness that makes constructive action so difficult.
Kate or Mark? Mark? No. Okay. One of the abiding principles of the entertainment business and the summit business is leave them wanting more, not less, and I think that's where we are. Thank you. Thanks. Thanks a bunch. That was great. Thanks, Kate. Thank you very much. Thanks, Anne. Thank you.